the skull, we have the dura mater, then the subarachnoid, the arachnoid mater, and the pia mater. Then in between the arachnoid mater and the pia mater is a space called the subarachnoid space, which contains the cerebrospinal fluid. So meningitis is defined as an inflammation of the membranes or the cerebrospinal fluid that surrounds and protects the brain and spinal cord. Meningitis can result from many causes, which can be both infectious and non-infectious. So by classification, meningitis can be classified based on duration and an etiologic agent. Then based on duration, when symptoms develop within a day, then it is termed acute meningitis. When symptoms develop over a day to 7 days duration, then it is called subacute meningitis. And then when symptoms develop over more than 7 days, then it is termed chronic meningitis. Subacute and the chronic form of meningitis usually have different forms of infectious and non-infectious etiologies. So based on etiology, depending on the causative organism, we may have bacterial meningitis, viral meningitis, fungal, parasitic, and non-infectious causes. And so we are going to be talking more of the bacterial meningitis today. So epidemiology. Globally, according to the CDC, over 1.2 million cases of bacterial meningitis are estimated to occur each year. The incidence and case fatality rates vary depending on the region, the country, the causative agent, and the age group. Without treatment, the case fatality rate can be as high as 70%, and 1 in every 5 survivors of bacterial meningitis will be left with permanent complications such as hearing loss and neurologic disability. So it is estimated that over the last 15 years, more than 700,000 cases of meningitis have occurred, and out of this, 10% died and more than 20% have serious complications. Epidemics of meningitis within the meningitis, but traditionally were associated with the Neisseria meningitis serogroup A. However, with the advent of the vaccines, this has however reduced significantly. In the Upper West region, the last outbreak that was recorded was in March 2020, which was in 2 districts, that's the Nandom and the Laura district, with a case fatality of 13.3%. During the outbreak, information from the surveillance revealed that it was caused by Neisseria meningitis X serotype, which unfortunately does not have a vaccine. So mass vaccination was not possible during the outbreak. So this table gives us surveillance data from 2017 to 2020 by district in the Upper West region. And if you look at the table, you notice that during the last outbreak, we had more cases within the Nadom, the Nadoli, and the Jirapa districts. In the Upper West Regional Hospital, in the year 2020, we had 25 suspected cases, out of which 2 were confirmed by PCI, and unfortunately, we recorded 2 deaths. In 2021, we had 21 suspected cases of meningitis, 1 confirmed with positive PCI results, and 1 unfortunately passed on. So this is a map showing the meningitis belt, which spans from Ethiopia in the east to Senegal in the west. So suspected case of meningitis is any person that presents with sudden onset of fever, that is 38.5 degrees Celsius per rectal or 38.0 degrees axillary, and one of the following signs: neck stiffness, altered consciousness, and other meningeal signs. Then a probable case is any suspected case where on lumbar puncture for CSF, the CSF macroscopically appears turbid or purulent, or on microscopic showing gram-negative Diplococcus, gram-positive Diplococcus, gram-positive Bacillus, or when the leukocyte count is more than 10 cells per cubic millimeter. So a confirmed case then is when there is isolation of the causal pathogen, that is either the Neisseria meningitis, Streptococcus pneumoniae, or Haemophilus influenza from CSF of a suspected or probable case, or by a hemoculture or a PCR. So the risk factors for meningitis are the extremes of ages: children less than 5 years and the aged who are more than 60 years. Chronic medical illnesses such as diabetes mellitus, chronic liver disease, renal failure, or sickle cell disease. Immunosuppression, people who have HIV/AIDS, steroid users, and transplant recipients, crowded living conditions, and contiguous infections such as paranasal sinusitis, paraspinal infections, and otitis media, functional or anatomic asplenia, and exposure to others who already have meningitis with or without prophylaxis. Other factors include chronic alcohol abuse, chronic malnutrition, intravenous drug abuse, and head trauma, which can either be penetrating or basal skull fracture. So predisposing factors vary based on the age. The causative agents for meningitis vary based on the age and predisposing factors. And for the adults between 18 to 50 years, typically the commonest causes are Neisseria meningitidis and Streptococcus pneumoniae and Haemophilus influenza. And then for those that are more than 50 years old, the commonest ones are strep pneumo, Neisseria meningitidis, and then as mentioned. The geographic location is also important because for someone who is found within the meningitis belt, it also increases the risk of meningitis. The route of transmission of the causative agents vary, but then most bacteria that cause meningitis are carried in the nose and the throat of individuals, and the spread is from person to person by respiratory droplets or throat secretions. Group B Streptococcus, however, is often carried in the gut and the genital organs of the females and can be spread from mother to the child around the time of birth. The average incubation period is 4 days, but this can range between 2 to 10 days. The route of infection typically are in 4 routes: the hematogenous spread through the arterial or venous spread, and this is the most common route of entry of the causative agents. Direct implantation, which may be through trauma or iatrogenic, and then local extension from infections such as sinusitis, infected to otitis media, and through peripheral nervous system, that is the retrograde neuronal, where infections with the peripheral nervous system can spread back into the central nervous system. The pathogenesis of bacterial meningitis is an interplay between causative and host factors. And so for the meningitis to occur, the causative organism is able to colonize the mucosal of the nasopharynx, and then is able to subvert the host defense mechanisms and survive, and then is transported into the blood. And so inside the blood, the causative agent is carried into the central nervous system, where it's able to multiply in the subarachnoid space. And so the damaging effect of meningitis actually comes as a result of immune response to the causative agents. And so with the release of interleukins and tumor necrosis alpha, there's damage to the blood-brain barrier, where there's increased permeability, allowing transendothelial migration of granulocyte and monocyte into the subarachnoid space. So depending on the serious degree of the infection, this infection may either be limited within the subarachnoid space. However, in a very severe form, the pia mater is breached and the infection can spread into the brain parenchyma, causing widespread cortical destruction. So clinically, how would the patient present? Commonly, a patient presenting with meningitis comes with fever, headache, neck stiffness, and altered mental status. And it's been shown that more than 50% of patients will present with at least 2 of either fever, headache, neck stiffness, or altered mental status. Other symptoms that they may come with include nausea, vomiting, photophobia, irritability, seizures, coma, and petechial rashes. So a history of a preceding systemic symptom such as myalgia or fatigue, anorexia may point to a viral meningitis. And so it's also important to look out for exposure such as exposure to someone who already had a similar illness is important because it may point to an epidemic disease. And someone's, an individual's sexual contact and high-risk behaviors such as the use of intravenous drugs, and also the sexual behavior of people. And it's been shown that for herpes simplex virus meningitis is typically associated with genital HSV infection, and also HIV infection can also cause aseptic meningitis. History of contact with animals can also present with atypical form of meningitis in aseptic meningitis. Previous medical treatment and existing conditions. A history of antibiotic use and NSAIDs should be elicited. And so usually this is important because patients who have been on antibiotics for some time may present in a subtle way because the symptoms may not be intense as someone who was not on antibiotics. And history of antibiotic use can also, affect your cultures when you take lumbar puncture, CSF for cultures, because it is shown that for an individual who has been on antibiotics to which the causative organism is sensitive to, after more than 24 hours, it usually affects the culture results of the samples that you can take. And so the presence of ventriculoperitoneal shunts and history of recent cranial surgery should also be elicited, as these are risk factors that can cause meningitis. Medical illnesses such as diabetes, chronic liver disease, and sickle cell disease should also be looked out for. The location and travels. The geographic location is also important because for an individual who has traveled to the meningitis belt or areas that have been recent epidemics should also be looked out for. And then the season to which the patients are presented. And in our part of the world, especially during the harmattan, the hot weather and the dusty environments are factors that facilitate the spread of the causative agents. So physical examination, patient may present with non-blanching petechia or cutaneous hemorrhages, and this may point to a causative agent such as Neisseria meningitis. And so patients who present with arthritis, it could be suggestive of a meningococcal infection. Focal neurological deficits such as isolated cranial nerve injuries may point to increased intracranial pressure or the presence of an exudate that is encasing on a nerve root. So other signs of meningeal irritation include the Kennick's, the Brudzinski, and the neck stiffness that we usually examine. However, these tests have been shown to have very low sensitivities. And so in a patient who presents and these signs are absent, it does not rule out a meningitis. Systemic and other extracranial findings may point to a specific causative agent. So morbilliform rash or pharyngitis or adenopathy may point to a viral etiology. Petechial rash that rapidly evolve into pepra may point to a meningococemia. And for genital vesicles may point to HSV2 meningitis. So diagnostic evaluation include the history, physical examination, as I've already mentioned, then the investigations. And this can be diagnostic and supportive. So diagnostic investigation with lumbar puncture for CSF analysis, then do culture and sensitivities with blood, respiratory secretion, urine, and skin samples, then a PCR can also be done. Other supportive investigations that can be done include neuroimaging, and which typically does not add more to the diagnosis, just it helps to pick up some complications that will come with meningitis. And so the other investigations that will do help you assess the organ function of the individual, and that will help you in adjusting the dosages of drugs that you'll be giving. And then also, as we mentioned, they may come with other comorbid conditions that such supportive investigations can reveal. So lumbar puncture. Now, for a patient who presents with meningitis, the diagnosis of meningitis is strongly considered. Lumbar puncture should be performed as soon as possible after you've ruled out any contraindications. And so the examination of the CSF is the cornerstone in diagnosing bacterial meningitis. So the opening pressure should be measured and CSF should be sent for cell count and differentials, biochemistry and microbiology as well. So herniation of the brain can sometimes occur in acute bacterial meningitis due to severe cerebral edema, acute hydrocephalus, or from lowering of CSF pressure from withdrawal of CSF. And so for a patient who have herniation, typically they present with altered state of consciousness, abnormalities in pupillary reflex, and they may have decerebrate or decorticate posturing. The contraindications to lumbar puncture include the signs of increased intracranial pressure. So the cushion triad, widened pulse pressure, irregular respiration and bradycardia, headache, blurred vision, confusion and vomiting, coagulopathy, infection at the insertion site, and suspected spinal epidural abscess are other contraindications to lumbar puncture. So for some selected group of patients, it is important to do a head CT scan before a lumbar puncture is done. And so for people who have immunocompromised state, history of CNS diseases such as a mass lesion, a stroke, or focal infection, patients who present with a seizure within the first week of presentation, papilledema on fundoscopy, abnormal level of consciousness, and patients who have focal neurologic deficits, CT scan is usually recommended before a lumbar puncture is done for this group of patients. So this table shows us the Csf analysis. And so for bacterial meningitis, you'll find that the white cells are usually elevated with differential of polymorphonical cells. Glucose will be decreased, and then there will be elevated levels of proteins. And then also, analysis of the CSF also revealed that the opening pressure is usually elevated in bacterial meningitis. And then it's also important to measure the glucose level in the CSF to compare with the serum glucose. So we must, however, know that because of the other comorbid conditions that patients may come in, so for people who have chronic liver diseases, they may have depleted glycogen stores. So their serum glucose level may be low. And so for people who also have diabetes, the levels may be high. So the comparison with the CSF and the serum glucose may not give a true reflection in the patients. So blood cultures are also done to complement the CSF culture, and this may help to identify the offending bacteria and occasionally its serogroup. And this can also help to determine the organism's susceptibility pattern to antibiotics. Serology and nucleic acid amplification tests are also done in the diagnosis of HSV and enteroviruses. So neuroimaging, CT scan, as I mentioned, generally does not aid in diagnosis, but in some patients, CT scan may show enhancement of the meninges when they have meningitis. Routinely, this is done to help in detecting CNS complications of bacterial meningitis, such as hydrocephalus, cerebral infarcts, brain abscess, and subdural empyema. So complications of meningitis can be grouped into neurologic and systemic complications. So for the neurologic complications, increase in intracranial pressure and cerebral edema, seizures, sensorineural hearing loss, subdural empyemas, brain abscess and focal cerebritis, hydrocephalus, and ventriculitis are some neurologic complications. And for systemic complications, septic shock, disseminated intravascular coagulation, hypotension, hemolytic anemia, and stroke are other systemic complications. So the management can be pharmacological and non-pharmacological, but then the objectives are to identify and eradicate the causative organism, then to prevent complications, to prevent spread to contact, and to maintain good nutrition in patients who have meningitis. So non-pharmacologically, patients who may present with symptoms suggestive of increased intracranial pressure, it's important to elevate the head and to 30 to 45 degrees to keep the airway clear and to pass an NGT for feeding if applicable. Pharmacological management, it is important to initiate empiric antibiotics promptly to get a better outcome. Lumbar puncture for CSF and blood sample for culture should be done, however, before empiric antibiotics are started. And so ideally, the antibiotics that should be used should follow a local sensitivity pattern. However, generally, these are the groups of antibiotics that can be used. And for between the ages of 1 month to 50 years, vancomycin plus ceftriaxone are typically used. And for people who are more than 50 years, we go for vancomycin with ampicillin plus ceftriaxone. So this also gives us a diagram showing the various causative organisms with the selected antibiotics and then duration that the antibiotics can be given. And so typically for Neisseria meningitidis, we go with the ceftriaxone and then vancomycin. You can give this between 7 to 14 days. So this gives a summary of the causative agents and the first-line empiric antibiotic treatment according to the standard treatment guidelines. So steroid therapy. It is important to use steroids as an adjunctive treatment for bacterial meningitis. So this significantly reduces hearing loss and other neurologic complications. And so this, ideally, the complications that come with meningitis typically occur within the first 24 hours. And so when a patient is able to present within this time frame, then it is important to give the dexamethasone shortly, that is within 15 to 20 minutes before the start of antibiotics, or it should be given together with the first dose of the appropriate antibiotics. We must, however, note that for a patient who has presented after 24 hours, and then we have to try and find out if the patient has already been on antibiotics. Because if the patient has been on antibiotics, then probably the use of the dexamethasone may not be that important. And then also, if the patient comes and is already on antibiotic, and you assess the patient and maybe the hearing is still intact, that means that the antibiotics have actually worked. And so it has kind of prevented the hearing loss from occurring. So other management options we have are for seizures, we may manage them with phenytoin or phenobarb, and for increased intracranial pressure, elevate head end of the body, and we give a mannitol. For shock and hypotension, may resuscitate with crystalloid until euvolemia is achieved, and for fever and pain, paracetamol can be given. Prophylaxis for CSM. This is recommended for patients 2 days prior to discharge and also for close contacts. And so ideally, prophylaxis is meant for people who have actually been in very close contact with the individual. And so, for instance, in a hospital setting, if workers who have been involved with suction of patient and have come in direct contact with the respiratory secretions of the patient, and so then the wife or the children of a patient who they have been very close contact with, these are people that typically we may give them prophylaxis. And then the recommendation is to give oral ciprofloxacin 500 milligrams as a single dose. This, however, should be avoided in pregnancy. And second line, we can use IM ceftriaxone 250 milligrams as a single dose. So bacterial meningitis is fatal in 1 in 10 cases, and 1 in every 7 survivors are left with severe handicap, such as deafness and brain injury. So even with effective treatment, significant neurologic complications can be reported to occur in as high as 30% of survivors. Patients who present with impaired level of consciousness are at increased risk of neurologic sequelae and death. A seizure during an episode of meningitis is a risk factor for mortality and neurologic sequelae, particularly if the seizure is prolonged and difficult to control. So the following variables are associated with adverse clinical outcomes. So for older patients who have increased heart rates, low GCS scores, cranial nerve pulses, CSF leukocyte count of more than 1,000 per microliter, gram-positive cocci or CSF on gram stain, and advanced bacterial meningitis can lead to brain damage, coma, and death. So prevention. The use of vaccines is the cornerstone in the prevention of meningitis. And so these vaccines have been licensed against the meningococcus, that is the serogroups A, B, C, Y. However, there is no vaccine against the X. And also we also have a vaccine against the Haemophilus influenza type B and the Streptococcus pneumoniae. Appropriate prophylaxis for household members and others in close contact to individuals who have been diagnosed with meningitis is also important in the prevention of meningitis. And it's also important to educate the public on the transmission of the causative agents. And so these were my references. Thank you for your time.
Thank you very much, Dr. Bakari, for an excellent job done. That was great. And it just highlight on the points that we need to take note of regards bacterial meningitis in adults. And more importantly, living in the meningitis belt is that time of this the year again where it's anticipated that cases of meningitis would be recorded by virtue of the pathophysiology and the risk factors that you did mention. So we've been able to do this in about 30 minutes, despite the fact that we were about 5 minutes late. I would say that just like you see in the chat box that I've just put up, there's a link to a very short survey there. It's just made up of 2 yes or no or graded questions that you just need to select. Kindly click on that and then please provide us with your responses so that it does help us to improve on the presentations. And as well, it also gives an option for your suggestions going forward. Thank you very much for helping to improve on these presentations by filling in this survey that has just been put up. So if you do have, we've come to the interactive part of the presentation, which we have about 27 minutes for. Of course, that's good timing. So if you have any question, any comments, any contribution, kindly electronically put up your hand and I would unmute you so that you can go ahead to do this. Whilst at that, we'll check in the chat box for any of such. So if you don't want to probably talk, but you want to type in the chat box, like I indicated while the presentation was ongoing, you could do this as well. So we would address those questions if you do have any. Yeah, so I see a question from Dr. Matilda. She's asking about, thank you for the good presentation. What is the benefit of dexamethasone in the pediatric population or pediatric patients? Dr. Bakari, do you have any response to that?
Hello.
Yes.
Okay, I have not specifically read more of dexamethasone in the pediatric population. And so per the presentation, I read more of the use of dexamethasone in an adult, and the essence is to prevent the sensorineural hearing loss that typically occurs within the first 24 hours, and also prevents other neurologic complications that may come with.
Okay, great. I think there was this point that was made when we treated the controversial use of dexamethasone, even in adults. I think for the pediatric population, correct me if I'm wrong, Dr. Matilda, those particularly with Haemophilus influenza type B, the Hep B meningitis, they appear to have a reduced risk of the hearing loss when dexamethasone is used in the setting of bacterial meningitis due to Haemophilus influenza type B. So, of course, if it's suspected hip meningitis, you would want, or DEXA would be recommended in that setting. Otherwise, other decisions regarding using dexamethasone in children for other etiological causes, other than that, then you may need to look at individualizing these because of the potential risks that are involved in DEXA use. If you have any addition, Dr. Matilda, you could kindly electronically put up your hand and then I would ask you to unmute and then go ahead. But this is what I remember in the pediatric setting. I think her hand is up, so I would ask her to unmute herself. Dr. Matilda, please go ahead. Dr. Matilda is a pediatrician at the regional hospital.
Okay, thank you very much for a wonderful presentation. I asked because when he was presenting, he said it could be used. It gave us the etiology by pediatric population and adult population. So when he made a statement, I thought it was to cover for all cases of meningitis, including our pediatric population. But what you have said is rightly so. That is what it is. So we don't routinely give dexamethasone to our pediatric patients unless we are suspecting the Haemophilus influenza B. Thank you very much.
Okay, thank you, Doc.
Thank you, Dr. Matilda. Any other hand that is up? Yes, okay, that was Dr. Matilda. So if you want to, if you have any comment, please put up your hand, and then we will unmute you to go ahead. Whilst at that, we'll look at the other questions in the chat box. So Bernard does ask, please, can you throw more light on the CT scan in immunocompromised patient before a lumbar puncture? Dr. Bakari.
Yes. So as I mentioned, the essence of the CT scan is one, you want to rule out other factors that probably can cause herniation in patients who have meningitis. And so typically for patients who have a immunocompromised state and the elderly, and for patients who for some reason present with just a minute to go back there so that I explain. Yes, so this is it. So typically, as I said, it does not really add up to any diagnosis. However, for such patients, because of the increased risk of herniation they have, it is always important to do the CT scan to rule out any possible cause of herniation before you go ahead. Because I mentioned earlier on that one of the things that can cause herniation is when you do the CSF and lumbar puncture and the sudden drop in the cerebrospinal CSF, it can cause the herniation. So it is important in such patients to do the CT scan to rule out any of those risks before you go ahead. If not, there's a chance that with the lumbar puncture, you may tip the patient into herniation.
Great. Yeah, so that just solves it because obviously in the immunocompromised, there are so many other causes of increase intracranial pressure or things or symptoms and signs that may herald a meningitis or may point you clinically to a meningitis. But in the setting of doing it before the LP, the main reason is, yes, as you said, the herniation. That's a bigger chunk of it. But even another thing that carefully we need to take note of is in the immunocompromised state, a lot of them have intracranial space occupying lesion, ICSOL, either from a tuberculoma, either from a cerebral abscess and all of that. And most of these things come in with raised intracranial pressure. So if you go puncture this person, you may just cause herniation and then you kill the patient. So it's of prime importance that you would want to scan the brain in that setting to be sure that one, these differentials are not the cause of the meningismus or meningism that the patient is tending to have, but more importantly, to also rule out increased intracranial pressure. Once that part has come up, I think I will throw light on doing the CT scan and the fact that it's a delay factor in initiation of antibiotics. So there's a component of it which we should have brought up as well. That's when you are going to do the CT scan. Obviously, it's going to delay the patient's, initiation of antibiotics. If you are going to wait, do that, rule out, raise intracranial pressure, before then you go ahead to do the lumbar puncture. Or it will take some time. Even in the rural settings, the 5 regions of the north, I wonder how many hospitals have CT scans available that you can do that before you puncture the person. So one of the things that we look at doing is to take the blood cultures, like he noted in the presentation. You take blood cultures, typically about 2 of them, and then you start your antibiotics. Before then, the patient goes to do the CT scan, comes back, and then you can go ahead and do your lumbar puncture, because you need to start the empirical antibiotics. More importantly, also because of the role of the dexamethasone that you are going to start. Obviously, if you elapse that time period, that will not be there because the sequelae would have already started, the hearing loss and all of that. And mind you, this is a sensorineural hearing loss. So once it ensues, that is it, which we really don't want to get to. So these are some of the technical details that you need to know about. Benjamin Opong does ask that, how does the risk factors influence the prevalence of meningitis? Can she, no, it's a he, can he explain more? So Dr. Bakari, regards the risk factors and the prevalence, the meningitis belt and all of that.
Okay, so regarding the risk factors, I mentioned of the geographic location. And so if you look at the meningitis belt, the geographic location, for instance, in Ghana, typically it happens within the northern and the upper regions. And that is because we have this hot weather condition, dusty environments that usually would facilitate the transmission of the causative agents. And so taking into consideration these factors, so someone who is within this zone or the meningitis, but typically would have increased risk of getting meningitis. And also the chances of spread of the causative organisms is high. And so taking this into consideration, these are factors that would influence the prevalence of meningitis. And so for people who have immunocompromised state, typically they are at risk of getting these infections and they are unable to mount immune responses to them. And so the infections are able to advance more in such patients. And then as they have the infection, they also have the chance of spreading the infection to other people.
Great. So obviously regards the various risk factors by way of geography. And then the other thing is regards the age. So that the thing about the geography obviously is what is explained. But again, the prevalence of meningitis, i.e. the different types of meningitis. I get the point that Benjamin is coming from the public health point of view, so that we may look at geographical differences and all of that. But in clinical practice, there are other factors that we'll look at and how they impact on the prevalence of meningitis, not just cerebrospinal meningitis. So if you look at the elderly, one of the common things is what do you call it? Meningitis from leptospira or something.
Leptospirosis.
So some of those diseases, obviously, you look at one, the age, and then you find out that most of these are common in a particular age group. And so the prevalence in that age group is higher. And so if you have a society in which a lot of them are elderly, like we saw when COVID did come in, leptospira monocytogenes, the one that is put up. So if you look at those more than 50 years, then the prevalence, if you have a society in which most of them, like population pyramid-wise, most of them are in the elderly groups. So you tend to have those ones being a common thing. Again, the geographical part is, as he has explained, we are, of course, in the meningitis belt. And usually we explain that, of course, it's of historical advantages and disadvantages. I'm not sure I want to go into that. So it's a couple of factors, and that then impacts on the prevalence based on the population at hand, i.e., if it's looking at the meningitis, but we'll look at geography. If it's looking at the age differences, there are various organisms regards those who are younger adults and those who are older adults, and then the various other risk factors like those who are on CSF shunts and all of that. But all in all, if you are looking at community-acquired meningitis, again, the prevalence of that will be dependent on the various factors that we've talked about. But there's another subcategory which we call hospital-acquired meningitis or hospital-associated meningitis. So again, if you have an elderly population where most of them are in homes, like hospices and other places, obviously, if there's an outbreak of meningitis, you tend to have these kinds of organisms being isolated. I hope that does explain it, but if you want to unmute yourself to make it clearer, that will be fine. And then he does say that it's a very nice presentation. Thank you. Emmanuel asks the difference between encephalitis and meningitis. Dr. Bakari. And then he asks that what's meant by abnormal level of consciousness, the GCS.
Okay. So meningitis and encephalitis. So meningitis, as I mentioned, is when you have inflammation involving the meninges and the cerebrospinal fluid. Then encephalitis is, as I mentioned, is when you have severe form of the infection, the meninges are breached, then the infection will spread into the brain parenchyma. So it tends to involve the meninges, then it will spread into the brain matter. So that is it. So meningitis typically talks about just the meninges and an inflammation involving the CSF. Then encephalitis means that the infection has progressed to affect the brain matter itself. And then abnormal level of consciousness is when you have patients with the GCS of less than 14 and below, 14 and below.
Fantastic. So we move on to the next question. I think that then Emmanuel does say that thanks for a great presentation. Sani says great and well in-depth presentation, doctor. In cases where children and under 5 are always at risk of both meningitis and cerebral malaria, sometimes those diseases can comorbid in same child. Please, at what moment will you be managing a cerebral malaria case and opt for treatment for meningitis as well? So essentially, it's asking the difference between cerebral malaria and meningitis. And when do you think it's cerebral malaria and when do you think it's meningitis? And do you have them both coexistent? Dr. Bakari, do you want to respond to that?
Okay, so regarding cerebral malaria and meningitis, so typically it will depend on how the patient presents. So your history, physical examination, and your investigations will tailor your findings to one. And so in the pediatric population, typically when the patient presents in meningitis, they may also present with this sort of fever and bulging fontanelles. And then also when you do the lumbar puncture, and then the findings you get, if you're able to isolate any organisms, and also, as I mentioned, the other supportive investigations that we do. So for instance, if you do a blood film for malaria parasites, and so depending on what you find, and then your history and physical examination, then you should be able to tailor your diagnosis to one.
Okay, great. Then I think we answered this regards the risk factors and prevalence. And then Dr. Salam says, a nice presentation, thank you. How do you differentiate meningitis from meningoencephalitis? And how different is the management? Dr. Bakari.
So meningitis and the meningoencephalitis, the difference, and then how different is the management?
Yeah.
Well, hello?
Yes.
So typically, as I said, so for meningitis, it has to do with more of the, as I said, the meninges and the CSF. And then also, depending on how extensive it is, it may spread to involve the brain parenchyma, it may involve the spinal cord. And so, as I was saying, since issues with the CT scan that we talked about are things that can help you probably, for instance, if there is widespread cortical destruction, this can be picked up on a CT scan. But clinically, I don't really know how you'll be able to differentiate between meningitis from a meningoencephalitis when there's involvement of the brain matter itself. But I think that with this, the investigations that I spoke about, especially the CT scan, you should be able to pick up if there's involvement of the brain matter.
Yeah, so that's right. So of course, meningitis, technically speaking, is the leptomeninges. So it affects the leptomeninges. The leptomeninges are made up of the arachnoid and the pia mater. So if you have infection of those two inner layers of the brain, the infection can track into the brain itself. And when it tracks into the brain, it's referred to as encephalitis. So obviously, following an infection like of the leptomeninges tracking into the brain, then we refer to that as encephalitis. Encephalitis simply is just inflammation of the brain tissue itself. And so typically, you can start off as meningitis or symptoms of meningitis. And once the brain gets infected or gets affected or gets inflamed, then you have encephalitis. Or somebody can come de novo and is presenting with signs and symptoms of meningoencephalitis. Typically, the main things are that once the brain itself is involved, the seizures and all of those things that do come in because the underlying brain matter itself gets involved. And then one of the things to take note of is, like he rightly said, it may be a bit difficult distinguishing clinically that is just a meningitis or is a meningoencephalitis. The good news is that most of the times the management is same, whatever that infected the brain or infected any of the distant, you would. And if the other symptoms do set in, like either the seizures, the hallucinations, the personality changes, or any focal neurological deficit, then you manage them appropriately. So the key thing is that, again, if you treat the meningitis early, you don't allow the infection to track into the brain, resulting in a meningoencephalitis, and as such, making the treatment quite a difficult one. Again, you can have viruses causing any, or you can have bacteria causing any of that, just like the case that we did in meningitis. In terms of the management, it's same. You treat the infection as it is, except that once it involves the brain matter itself with the various complications, then you are looking at treating them as and when they come in, like the seizures, you need to treat that and all of that. So these are the things that we should take note of. The CT scan and those is in the setting of meningoencephalitis, especially if it's an MRI, may be able to give more benefit rather than just the lumbar puncture or only the CT scan. The treatment is just as for the various underlying causes. Then, Doris is asking, is the use of dexamethasone still relevant after the first 24 hours? I think you addressed that, but you can talk about it again.
So as I mentioned, so it depends. So if the patient has come after 24 hours, and then there's no history of the patient being on any antibiotics, and then also if you assess the patient and you feel that the patient, the hearing is still intact, it's still prudent to go ahead and give the dexamethasone even after 24 hours. But it's just like if the patient then comes and maybe the neurologic, the sensorineural hearing loss has already occurred, then giving the dexamethasone is really not going to have any effect, because the essence of giving it is to prevent the hearing loss. But if the patient comes after 48 hours and the hearing is still intact, then it's still prudent you may still consider it. There are other sources that even mentioned that we can extend it to maybe, as I said, like within 15 to 20 minutes. Some sources say you can extend it to like 4 hours, some say 12 hours. So, but then after 24 hours, if the patient, the hearing loss has not occurred, then it's still important to give it, at least to prevent it from happening.
Yeah, so the truth is that these are guidelines that, what do you call it, determined or depend on your country of practice and all of that. Unfortunately, we don't have local guidelines. So you realize that the British and then the Europeans do, they do allow up to 12 hours, the 4 to 12 hours that you mentioned. The Americans are quite drastic. So if you get in and antibiotics have already been started, they won't start you at all and all of that. So it's weighing, the key thing is that weigh the pros versus the cons, the risk versus the adverse effects of your dexamethasone. It's not like it's an all good thing. Obviously, it also has a side effect. So if you take it patient by patient basis, after it's elapsed what the time interval that you've given, if you still think that there is, on an individual basis, you think you benefit from it, you may go ahead. But guidelines are always made to guide us. They are not cast in stone. So these are the things, and that's the reason why we go on the ward to examine patients and all of that. Otherwise, robots would have been doing our job, is that also? Charles does ask, is there a chance of survival amongst the fungal meningitis? A number of them I've seen never made it. Okay, unfortunately, we didn't do fungal meningitis today, but I do agree with you. Fungal meningitis, of course, is mostly in the setting of immunocompromised states. And a couple of them, like either the cryptococcal meningitis, it's a fungus. And so most of them come in with raised intracranial pressure. And if you don't relieve that, that's the only thing that in the developing world, if we cannot manage better, we do what we call serial LPs. If you don't, it keeps getting blurred vision, the eyes are gone. It's a cause of preventable blindness. And a couple of times we do lose them. So typically the prognosis isn't too good with those forms of meningitis, because most of the times they occur in the immunocompromised state. And then the fungal agents, the systemic antifungal agents are not as of good penetrative ability, like for the CNS, the blood-brain barrier, and all of that. So these are some of the factors that do account for the poor prognosis. But like with the fungal meningitis, like things like cryptococcal meningitis and all of that, there have been a couple of instances we've managed them and they've been able to get out of it. It's just that one, the cost of treatment, doing the standard treatment for them are quite expensive. And so we are not able to sometimes do that. And so we end up probably just giving either the third or fourth line, which is our good old high dose of the, what do you call it, trimethoprim sulfamethoxazole, otherwise best called the Cetrin, 19-20 milligrams twice a day. That's like about third line. If you really look at the Infectious Disease Society of America, their guidelines, guys, cryptococcal meningitis and toxoplasmosis and all of that. But we do with what we have. And so there are several factors accounting for the reason why some of our cases do not survive. But mind you, most of the times we do forget about the greatest weapon, because in the setting of the immunocompromised state, be it RVI or any of that, the best actually is the antiretroviral treatment itself. And so we may all be pushed towards looking for antifungal agents, systemic antifungals, and all of that, but forgetting that the main thing is to raise that CD4 count, which in itself will help the immune system to be able to get hold of this. Dr. Rahima asks, is there any reason the dexamethasone given before antibiotics or given together? Is there any reason the dexamethasone given before antibiotics or given together? And also, how long should they be given? Yeah, I think you mean why should they be given before or should they be given together? And how long it should? Dr. Bakari, do you want to address that?
Okay. The reason is because it's been shown that when you give the dexamethasone together with the antibiotics, then it's been shown that the outcome is more when it's either given shortly before or together with the antibiotics. And so usually for patients who are able to come within this period and you give the dexamethasone either shortly before or with the antibiotics, the outcome for such patients has been shown to be better than as compared to other groups of patients.
Yeah, so obviously, like we said, the main thing is to prevent the neurological sequelae. And so if you wait till the sequelae ensues, of what benefit is it? And that's why it's best given just before or at the time of the what do you call it? At the time of giving your antibiotics. Otherwise, once it starts, usually it's of no much benefit. All right. So like I put up, kindly click on the link and then provide us with just only 4 direct responses so that we can improve on the presentation. If you just scroll up the chat box, you see that. We are on to the last but one question. In clinical practices from Dr. Salam, in clinical practices, how feasible is it to respect the recommendation of giving DEXA in the pediatric population before or with antibiotics in H. influenza meningitis cases, since we don't have the luxury of waiting for culture results? Yeah, so I would defer this one to Dr. Matilda to give an expert opinion since she's the pediatrician. Dr. Matilda, you are, I don't know if you are, yeah, I think you're still there. Please, I'll ask you to unmute yourself and address this question.
Can you read the question again? I didn't get it well.
Yeah, so she was asking that clinically it's quite difficult determining that is Haemophilus influenza unless you do the cultures. So how feasible is it in our environment to be able to start the DEXA for children with Haemophilus influenza? How will you determine that it's Haemophilus influenza and start it even before getting the cultures? Because the cultures will take forever to come. Unfortunately, let me unmute her again. Dr. Matilda, sorry, you're muted, so you can unmute yourself now.
All right, thank you very much. So in practice, we do not routinely give the dexamethasone. It is difficult to clinically tell that it's Haemophilus influenza as well. But in majority of the cases, it's usually not Haemophilus influenza. So it's by culture, you'll be able to tell that you are dealing with Haemophilus influenza, but generally we do not give the dexamethasone as a rule for every meningitis case that we get.
Great, thank you. I think that's it for the questions that are in the chat box. And as well, we've gone past the hour. We thank you so much for joining us today. Benjamin says, thanks so much. Whittle Alfred says, great and very educative presentation. I cannot but to thank Dr. Bakari as well for an excellent job done. This has really educated all of us regards bacterial meningitis of the various types, not just the Neisseria meningitis causing cerebrospinal meningitis. And as well, also highlighted on the fact that we live in a meningitis belt. And so we should be on the high alert for the cardinal signs of meningitis. And if they do present, you should have a low threshold or a start of empirical antibiotics with or without dexamethasone, depending on the time of presentation. And if that LP cannot be done as a result of increased intracranial pressure, take that blood culture, 2 of them, and start the empirical antibiotics. Because meningitis is 100% treatable, bacterial meningitis. So it's not right that we lose people from meningitis. If you look at the mortality indices that he put up, 2 of them were lost last year. 1 was lost this year. No, 2 of them lost 2 years ago. That was 2020. And 1 was lost this year. Obviously, most of these cases presented late, and usually it's quite difficult treating them once the sequelae has ensued. So let's be advocates so that in this time of the dry season where the meningitis is endemic around the hotness of the environment and all of that, because of the breakages in the nares, giving it a focus for the infection to get in. So if you do have the clinical symptoms, you don't err on the side of caution by starting the antibiotics. So we recommend that you should do this. Some few announcements. From the month of May, we would have 7 Canadian medical professionals joining us in the Upper West region. 3 of them are specialists, 1 nephrologist. So they would join us in our presentations. I think a couple of them may do a presentation or the other. As well, there's a biomedical engineering, week-long biomedical engineering workshop that Ghana Medical Help would be organizing from the 13th to the 16th of May. So the MedSubs are on the platform as well. It's recommended that you will see in the letter that will come from the regional health directors of both upper regions. Kindly recommend your biomedical engineers so that they get trained, so that we can keep our medical equipment and be able to use them and fix them when they do break down. Because it's an expert team that is holding this in conjunction with the Canadian Biomedical Society, and then the chief or head of biomedical engineering from the headquarters of the Ghana Health Service. So really we have a lot of experts who would be in the region to do this. Let's make use of this opportunity. And like you always see on the platforms, we would announce other subsequent presentations, I think from next week. And then if you can make time to join us, I think we learn from each other. It's been great having all of you. And it's been great about the comments that have been put in there and the education from Dr. Matilda and others who do join us every week for these presentations. I'm sure we do build a lot on our clinical acumen by listening and participating in these presentations. We thank you so much for joining. If you haven't keyed in or you haven't clicked on the link to provide your responses to improve these presentations, kindly do. Just scroll up and you see the link I put there. Within 60 seconds, you would be done. It's just a yes or no, a graded kind of questionnaire. Only 4 questions, 1, 2, 3, 4. Thank you very much. And please take good care of yourselves as we meet next week for the next presentation. God bless us all. Thank you, Dr. Bakari. Bye-bye.
All right, bye.